Thank you for inviting me to give this talk. First, I would like to introduce myself. My name is Ali Dabaja. I am Director of Male Sexual Health and Infertility at Honeyford Hospital. I'm a Detroit native, so I grew up in Detroit and went to Wayne State School of Medicine just across the street from here. So, this talk is titled Cancer in General. However, I'm going to try to focus it on bladder cancer, and because I know most here are for that discussion. So, just to start with, all cancer treatment, including bladder cancer, have the potential to alter sexual function. That is, including surgery, chemotherapy, radiation, and hormonal therapy. And about 40 to almost 100% of the patients experience some form of sexual dysfunction. And this sexual dysfunction causes major quality of life issues. And so when intervention occurs, and it occurs early, you can actually prevent up to 70% of the times by improving the sexual function of the patients. So this is a quick survey study that was published by a major journal that asked patients why they haven't asked their doctors about sexual function. And most of them thought they felt that the doctor will be uncomfortable discussing the issue. Others thought the doctor will be dismissive. And last, they thought there might not be treatment for the disease. So, there's a lot of barriers. Doctors usually are, they think that somebody else is going to take care of the issue. I am a physician myself, and I admit they do that sometimes. If the patient is not asking, they might not care. I don't know how to help, or I don't know what the treatment plan is. I don't have time. I'm too busy to take care of other things. I don't agree with the lifestyle of the patient. They think that the patient might be too old, too sick, too young. That is not the case at all. And they might think that they are going to offend the patient by asking. And sometimes the patient don't ask because they think that, well, I survived cancer, I should be happy. That is not the case. That's quality of life. And sometimes the patient might think, oh, well, if it was important, that my doctor would have mentioned it, right? Well, that is not the case either. And now we're going to go over all those things, all these concerns, and we're going to try to break down those barriers. So sexual dysfunction in men, especially in bladder cancer, is affected by all type of treatments for bladder cancer. So when you're getting treated for bladder cancer, you probably had surgery done, maybe have received chemotherapy, radiation, as well as hormonal therapy in some instances. Well, if you received chemotherapy or radiation or hormonal therapy, you're more likely to be affected with erectile dysfunction. You might have a decrease in libido, that is the sexual desire. You might have some ejaculatory dysfunction. You're not able to ejaculate. Enlargement of the breast, penile shrinkage, or testicular atrophy. When you receive radiation, you have very similar effect, and sometimes you might have urinary incontinence. And surgery does the same thing, as well as altering the body image of the patient, or having pain during sexual relations, or having ejaculatory dysfunction. Well, surgery for bladder cancer, it involves removing the cancer in the bladder itself, but also you're moving most of the internal sexual organs, and that will have substantial changes in your overall sexual function. Although in men, the driving force is erections, other important components of the sexual process are also affected during surgery and during treatment. The desire. You're receiving chemotherapy, your testosterone levels are going to be down. So therefore, your desire is going to go down. Orgasmic function might go down. You're not able to reach orgasm, or you're not able to ejaculate. That the regularity of the erections. You might not have erections when you want them. That is very frustrating. Deformities to the penis. Some men report that their penile length might decrease, or they might have curvature to the penis. Again, I talked about low testosterone, low energy level from the surgery or the chemotherapy and radiation. Maybe the patient have some psychological problems happening between them and their partner, or social issues, and body image issues also come up. Well, you might not have automatic low testosterone, and that's mainly for men. The chemotherapy and the radiation might lead to that. So in most instances before surgery, you might get chemotherapy. So that might lead to low testosterone. Or if you have received radiation after surgery, that might lead, or chemotherapy, that might lead to low testosterone. And sometimes you have that as a separate disease.
So if you don't have it,
Yes.
okay.
And you might, in other instances, you might have that as a separate entity that have not been diagnosed. So the sexual health in general requires everything coming together. You know, you need the function there. You need to be able to get an erection, or you need to have an orgasm. The physiology and the anatomy have to be in place. You have to have interest. That again, libido, motivation, the attraction to your partner, and the satisfaction, satisfying yourself and also your partner. So all those things have to come together to have a full response. So when you look at sexual dysfunction after cystectomy, it's like a puzzle, and they all have to come together, and that's why, and I'll explain step by step what happens that will lead to this sexual dysfunction. During the surgery or during the radiation, you'll have damage to the nerves, you'll have damage to the vessels, and those damages are something you can't control for. It's part of the surgery. These things will lead the patient, and specifically male patients, to have trouble getting and keeping an erection. Then you also have the surgery, effect of the surgery on the patient. You also have the effect of chemotherapy and radiation on the patient. Those aspects of the treatment will cause the patient to have low energy level. Therefore, they're not interested in or not able to perform. They're too tired. They want to go to bed. They want to rest. So that will dampen the sexual desire. Again, as we discussed earlier, the cystectomy involves removing internal sexual organs that lead to ejaculation. So you might have orgasm and ejaculation will not occur. This is sometimes very troubling to some men. You know, they want to be able to ejaculate. That is a very important part of their sexual function. So that can be distressing. Then you have the shortening of the penis or the penile deformities or scar formation. Those things also can be distressing. Surgery and radiation can cause to urinary leak. Sometimes after the surgery, if you have neobladders, you will have leakage during orgasm, or the orgasm might not feel the same way it used to in the past. So some of the orgasmic problems that happen after surgery are absence of orgasm, that is either due to the low testosterone or because of sexual dysfunctions that have led the patient to condition themselves to that point. Change in intensity, leakage of urine at the time of orgasm, we call it climacturia, and pain upon orgasm. That is because the pelvic muscles are contracting, causing discomfort, and that's called dysorgasmia. And then we talked about chemotherapy leading to low testosterone, causing low libido and erectile dysfunction. Testosterone is not just important for sexual function. Low testosterone can affect the overall physical health, muscle, strength. Also, it will cause degradation of the bone density. So it is important that these things being addressed as part of the treatment. You know, you survived your cancer, congratulations, but also we need to take care of your overall health. And things that also will bother the patient and their partner is the body alteration, emotional and physiological stress. You know, you've been through a lot in the last 6 months. It's time to start recovering. Stigma associated with urinary diversion. Having an ostomy is not an easy thing to walk around. It's not easy to have sexual intercourse or be attracted to your partner when you have these changes in your body image. And strains on relationship, not just sexually, emotionally. You know, your partner been through a lot in the last 6 months. On top of that, you know, some financial strains that might play a role. So all these things come together and causes the patient to kind of withdraw from their sexual health. So how do we treat all these things? I'm going to go step by step about treatment. And the success for treatment of sexual dysfunction is trying to realize what the problem is and try to attack that first. So you want to start treatment even before the surgery. You want to talk to your doctor. Ask what kind of surgery they're doing on you. Why? Some studies have shown that if you do the surgery with certain patients might not qualify, but certain patients will qualify for a surgery where the nerves are spared, or the prostate and the seminal vesicles are spared. But that, again, I have to, with a caveat, with making sure that your cancer allows that surgery to happen. Not all patients can qualify for these kind of surgeries. So some studies have shown that if you spare the nerves or the prostate or the seminal vesicle, if you qualify for these kind of surgeries, you will do better. Your sexual function will be better. Right after leaving the hospital, you're done with the surgery, you need to be on a penile rehabilitation program. You need to be on a daily medications that will allow your penis or the penile shaft and the penile tissue to rehab. The goal is to allow good blood flow to the penile shaft and to get at least 1 or 2 erections every week. If you're not obtaining those erections with pills, you need injections. And there's algorithms where we follow and we tell the patients, daily small dose of Viagra and two times a week where you should take at least large dose of the Viagra to get an erection. You need erection. A penile tissue is a muscle, and a muscle needs to stretch, a muscle needs to be used. I will say this: you lose it, you use it, or you lose it, and we say it out there, but it is true. You have to rehab your penile tissue. Yes. I think right after removing of the Foley catheter, if you have a Foley catheter, when you go home and you're discharged, you should be started on penile rehab. Their studies showed that the longer you wait for rehabilitation, the more likely you will have erectile dysfunction. If you don't do good penile rehabilitation, you will form scar in the penile tissue, and therefore that cannot be reversed. So there's some studies that show the earlier, the more aggressive the penile rehabilitation is, the better outcome you have in sexual function and erectile function. So some of the treatments for erectile dysfunction, as you all know, are the pills. Those are the Viagra, the Levitra, and the Cialis. Others are the injections, and we'll go over that briefly. When we use the pills, I think they all work the same. It's practitioner's preference and side effect that make us choose between one or the other. If the pills fail, then we step up the game and we give you something else. And we usually give intraurethral pellets. Those are Muse. It's a little pellet you put into your penile, into your urethra, and help you get an erection. Some practitioners don't like to use it. I personally, if the patient asks for it, I'll give it to them. I don't have a preference for it. Now, what I do in my practice is I start the pills. If the patient don't do well on the pill, or I see that they're regressing on the pill, I actually do a penile ultrasound. And I try to determine what the blood flow to the penis is. I look at the arterial inflow and the venous outflow. That will help me determine if they are going to qualify for injection or other forms of treatment. And injections are usually drugs that you put right into with a small needle, like a insulin syringe needle. You put it right into the penis, and will give you an amazing erection. Some patients are really satisfied, and they're very cheap. Comparing to pills, they're about $4 an erection, basically. Now the way the pills are covered under insurance, the pills cost about $20 an erection. So they're really cheap. So this is a kind of chart giving an example of the cost of the pills. And if things don't progress and the patient don't do well on injections, then we talk about implants and other tools that the patient can use. Addressing the issue of ostomy, body images and ostomies. Some patients might complain that there are some urine smell or the odor is not tolerated. I recommend using tight supplies. They don't like the way it looks. There's some high waistline underwears that they can use to kind of conceal it. Also, there's some websites where you can actually buy ostomy supplies that have actually decorated like lingerie. So you can actually do that and use those. And regarding intervention for partners-related concerns, as as we were talking earlier, open communication is the key. If you're having pain during intercourse, use pillow, prop yourself, be comfortable. If a patient's having pelvic muscle spasm, use Kegel exercise to relax the pelvic spasm. If there's any evidence of depression, treat the depression. And for patients who are neutropenic, especially if you're on chemotherapy, it's very important not to have vaginal or anal intercourse because that can cause the person to go septic. In regards to orgasmic dysfunction, we talked about the absence of orgasm. I recommend that we use vibrators because it stimulates you very. I try to get to the stimulation to the level where you can reach orgasm. If you are leaking during orgasm or during intercourse, I highly recommend that you empty your bladder or your neurobladder in some instances to make sure that you're not going to leak urine when you reach orgasm and climax. And pain up on orgasm, that is usually due to pelvic muscle spasm. So I tell my patients to take muscle relaxant, Flomax. It's actually we use for treatment of BPH. It relaxes the pelvic muscles, and most instances that pain is relieved.
Is that for men and women, or just for men?
Yes, I have seen some female specialists use it for female pelvic pain. And these are some websites you can visit. They're on a sheet that you got. They're support group websites. They have a lot of information and links to other websites you'll be able to use. Other aspect of what I do and with my patients is fertility. Cancer treatment is very detrimental to the fertility potential, and a lot of young patients now are being diagnosed with cancer, and so those patients need to keep in mind that after surviving cancer, that they are going to live mostly a normal life, and it's very important to have children of your own. And so I encourage to think about those things before treatment, and we'll talk a little bit about that and how to make sure that their fertility potential is preserved. When you're receiving chemotherapy and you're having sexual relations during that time, it is very important to use condoms because chemotherapy is secreted into the semen and sometimes the vaginal fluid, and you don't want to expose your partner. Again, when you're receiving chemotherapy or radiation, try to avoid having pregnancy within 1 to 2 years because most of your germline cells, the sperm and the eggs, might have some dysfunction from the treatment that you're receiving. And yes?
Will the same hold true for BCG treatments?
Yes. So for BCG treatment, it's very important not, there's usually given instruction that you're actually supposed to put chlorine in the toilet, clean the toilet, and if you're having intercourse, you definitely should be wearing, you should avoid intercourse the week that you're actually receiving BCG, and you should wear condoms during the treatment plan.
What does that stand for, BCG?
It is a medication that we give for patients that have bladder cancer, where you install this medication. It's actually TB strain of a TB strain that we use to install into the bladder, and helps the bladder fight off cancer cells. And again, please prevent using. If you're neutropenic and you are having chemotherapy, you don't want to put any devices into the vaginal area or having any intercourse during that time. Well, during neutropenia, so when your white blood cell count is lower than a certain number, you're not supposed to. And so that's when you actually, whenever you're getting your blood drawn, talk to your oncologist and make sure that you're not below that number. Yes, during the whole, I would recommend during the whole period, because it is given on regular period, and so you're getting it for 6 weeks, and you're supposed to do that during the whole time. I would do it during the whole time. And then talking about radiation and effect on fertility, in young female who are getting radiation, the uterus is usually affected with the radiation, and the uterus is usually affected with radiation, and that puts the young female at the risk of spontaneous abortion, preterm labor, and low birth weight. Also, men who are getting radiation and chemotherapy, there is a decrease in the testicular function. Again, as I discussed earlier, the testosterone level might be low. There might be some effect to the ovaries, and the effect to the ovaries is determined by the age of the patient. So that also has an effect. So we talked about the different surgeries that can cause infertility. That is orchiectomy, penectomy, prostate surgery, hysterectomy, and bilateral oophorectomy. So options for fertility preservation, I recommend patients to do sperm banking ahead of time. For female patients, I recommend either preservation of eggs, embryo freezing, or ovarian transposition if you're getting radiation to the pelvis. There's a lot of fertility treatment can be really expensive. There's a lot of help you can get. Certain states require that patients get some coverage, and there are a lot of support groups that can help with financial means for that. And these are some of the local sites for sperm banking that you can visit. You can also see your doctor who can direct you for those. And is there any questions? You don't need a referral to see me. If you want to make an appointment, then you can. I can give you my contact information. But I'll have some cards out, and you can just grab one on your way out. That is a very good question. The injection itself has been shown to cause some scarring, and so we try to minimize the amount of injections we do. And if the patient doesn't need injections, we try not to do it. But that is a risk of the injection. But again, if you don't do injections, you're going to develop penile scarring in itself. So it's catch-20. Yes.
Do you have patients
VED?
Yes.
Penile pump are. I don't like them personally. Some patients do like them. The reason I don't like them, the key for penile rehabilitation is to get oxygen to the penile shaft. These devices, like the VED devices, they trap venous blood into the penis so that it's low in oxygen. So that you're really not doing the job of what you want to do, that is supplying the penile tissue with good oxygenated blood. So that's the reason why I don't like them. Well, that's the pills and the injections, and that's why I prefer to go that route with my patient. Now, if my patient wants the device itself, I tell him go ahead and try it. I would never stop him from using it, but I'll tell him my thought process on that. That is the question that everybody's asking. If you have low testosterone and you have symptoms from low testosterone,
How do you know if you have low testosterone?
we measure your blood level. There's a test that I do, a blood test, simple blood test that I do to measure your blood level of testosterone. And then there's a screening questionnaire called the ADAM questionnaire where I ask you a certain amount of questions. If you have a certain amount of yeses or nos, plus your blood level, then I can find out if you have low testosterone and if you are symptomatic from having low testosterone. If you have the two, if you have low testosterone and you are symptomatic from having low testosterone, then I think you qualify for treatment. And if you're treated, you would definitely see some improvement from the treatment. Now, the key with treatment is monitoring. Whenever you're giving someone testosterone, you want to monitor the level. You don't want the level to go too high. You also want to monitor the side effects. You want to monitor things that can be affected by testosterone, like by testosterone treatment, such as hemoglobin, and also your PSA, if you still have your prostate, or if you had a history of prostate cancer. So there's a lot of things that we need to follow. They are safe if they're used right and you're monitored. Well, you don't gain most of your function until probably 2 years out from the surgery. Recovery takes about up to 18 months to 2 years. But you should not be waiting a treatment till 2 years out. You should start treatment and try to get an erection right at the time of discharge. So the research showed that that if you have patients who have nerve sparing, if you spare one side, you're good. If you spare both sides, you're golden, because the more nerve you spare, the more likely you are going to have return of sexual function and erections back. Regarding prostate sparing, only certain group can qualify for those, because it is, you are leaving a lot of organs and tissue back, and the fear is that if a bladder cancer patient have some involvement of certain areas in the bladder, you might not be able to spare the prostate. So those surgeries are really preserved for certain type of patients. I think the literature is out there saying that if comparing to patients who had no prostate sparing, the likelihood that you will get your erections back is as high as 60%. So it's better, but not everybody qualifies for that. So I don't want you to get the wrong message and leaving here thinking that, oh, my doctor did not leave my prostate with seminal vesicles. It's when you do this surgery, your cancer comes first, then function. And so we want to make sure that I convey that to you. Whenever a surgeon does surgery, during the surgery, their goal is cancer control. And then, then comes this nerve sparing. So usually the technique that the surgeon used will know if they spared the nerves or not. So they will know. So, sometimes you spare the nerves, but the problem is the nerves are still asleep from the trauma from the surgery. So when you're sparing the nerves, but the nerves are still asleep from the surgery, that also can take time for the nerves to wake up. So that maybe takes a few months for it to happen. So there's also that aspect. Hope I was able to answer all of your questions. It's a big topic. You can always email me if you have any other questions.